Welcome back to part 2 of the SIBO Doctor podcast, and let's jump right back into it. So what you're saying is that when you see a fungus present, assume some level of immune suppression, at least locally, like mucosally. Is that what you're saying?
It could be local, okay, but it could also be systemic. And we're not in a position to say, we check a few of the immune, markers if necessary, like we do the immunoglobulin levels, IgG subclasses, we do CD57, we do the CD counts, I look at the natural killer cell activity. And one or the other may show, but I'm not really convinced that there's not more into it. And I'm not an immunologist, but I think eventually if somebody studies this, they may be able to come with panels that you can check and see where the dysregulation might be present. I don't think this is just local. I think it's beyond that, because patients like this may also have more sinus infections, recurrent urinary tract infection. They get ill frequently. There's more into it, if you will.
So just for people listening, because it's mostly there's a lot of patients always listening to the podcast, and I'm hoping that they're still with us. So I'm just going to summarize a little bit. So what we're discussing here is that the presence of methane, especially higher levels of methane, are they more clinically related, or do we see more elevation of fungal overgrowth or the presence of fungal overgrowth in these patients? And both Dr. Rahbar and I seem to see a lot of fungal overgrowth, whether that's with or without methanogens. But with methanogens present, I do think I am seeing more positive yeast markers especially on the organic acid test, which is pretty much the only test I do and the mycotoxin profile. Although the mycotoxins, let's talk about that for a second, because my understanding is mycophenolic acid and ochratoxin A can be released by or secreted by Aspergillus, by Penicillium, but also Candida also releases some levels of mycophenolic acid. I don't know how much, but so these mycophenolic acid is very immunosuppressive, as you've mentioned. So yeah, not sure where I'm going with that question. I'm just summarizing.
No, that was a good summary. Okay.
Because we're all, as a clinician, for me, when it comes to Candida, it's probably the most tenacious organism that I treat, probably more tenacious than methanogens. And I haven't thought about first using antifungals before I dive into treating methanogens, which is really a great thought. And I'm going to give that more thought and probably try that out. Getting back to your thoughts on methane and levels of methane that you find. With my methane presentation that I've done, I've actually seen some benefits with methanogens being on board in terms of a metabolic conversion of carbohydrates to energy in athletes, having less trimethylamine oxidase present in people that have higher methane levels. So there appears to be also some benefit, whether that's good to talk about here or not, but I just, I'm always careful to not vilify one organism, because on some level, I think that methanogens evolved with us and were actually very beneficial for our evolution because they helped us extract more calories from food by slowing digestion, and a large percentage of the population has presence of methane without any apparent clinical problem or relevance. So, this is always the thing that I struggled with when I researched methane and methanogenesis. And, but, Candida at its basic level is also not really a pathogen. It's a commensal organism. So maybe we are dealing with commensals that are forced into pathogenicity or being more pathologically relevant under certain circumstances, So these are the questions that conversations like this raise for me.
Yeah, And I totally relate to that. I just also wanted to mention that we're seeing less and less Candida albicans. The other subspecies of Candida are showing more and more, at least in the samples that we see. And I think if you start to do the organic acids and maybe the stool test, maybe I actually do less organic acids. I do more stool tests because as a GI, I need that information. But it's ideal to have both of those, then you can say, okay, one or the other can give us the guidance. And again, the idea of doing some fungal antibodies has appealed to me. This is something we're now considering more because sometimes I need some evidence that this idea is corrected. But there are other fungi, as you mentioned, that they're not Candida albicans. And Candida albicans could be parts of our, normal microbiome. And my recollection is that, fungi are about 0.5%. So maybe that 0.5% goes to 1% or 2%. And when that proportion increases, maybe it produces clinical picture. And it could be that maybe the same bugs are there, just the proportion of them are increased. Yeah. Another thing which, I kind of mentioned in my talk last year was, and I may be wrong about this, but we have several patients where we took them off egg yolks. Okay. I call it, this is a spam caller. Okay. Okay. We saw that some of the high methane patients, they were eating a lot of egg yolks. And when we asked them to stop that, spontaneously, the numbers came down. And one of them was not responding to the treatment. Eventually, by stopping the egg yolks and reducing the overall red meat, we were able to normalize the methane level. Now, this is fascinating because of why. And I presented some of the literature on this one, that the choline, and carnitine, through that enzyme, the trimethylamine oxide in the liver, they produce TMAO. And, this molecule is basically a carbon with, trimethyl is basically one carbon and, some elements of CH3 attached to it. And it's very easy for that to become the substrate for the methane. Okay. Indeed, I gave this as a quiz to my son who was doing chemistry. I said, look, can you change this molecule from this to CH4? How many of this molecule is going to give you how many molecules of the CH4, which is the methane? And I am sure that the nature has some enzymatic pathways that does that. We know that at least in cow and in, such enzymatic pathways are present. And it may be that we do the same thing.
Yeah, that's this article I was referring to, is that people that had higher methane had lower TMAO, or trimethylamine oxidase, I think. So it's definitely already in research that we see a benefit of, if you think that having methanogens on board is a benefit in that regard, that it would lower the risk of atherogenesis because of a reduction of that enzyme. But I've never, that's fascinating that you just reduced eggs and meat and saw a drop in methane. So interesting, very interesting, yeah.
Yeah, the case is actually among the presentation we did last year. And the numbers, I think, came down by about 40-50% without any treatment.
That's significant, yeah.
Okay. So when we see high methane, is usually one of my standard questions to ask, do you eat a lot of red meat, or particularly, egg yolks, which is high in choline, and choline would become a substrate for the liver. And if the liver has the proper machinery, it can turn that into trimethylamine oxide. through that enzymatic pathway.
You and I, we always like to go down rabbit holes, don't we? We just like free
We may get
thinkers,
stuck
free
there.
association. But I kind of wanted to go back to what you talked about, this bile gastritis and bile reflux, because you mentioned several years ago at one of the conference, and this is always so great to talk to actually a gastroenterologist who does the procedures. We don't have that luxury of actually visualizing anything as naturopathic physicians. We refer to you for that. So, can you talk to us about the connection between high methane and bile reflux?
Well, it's the connection between high methane, high hydrogen, fungi, parasites, anything that is primarily in the proximal gut. And this is my observation. If the proximal small bowel is contaminated, it appears that the body has a language of its own and say, look, I'm not going to put the food down into small intestine. That area is not clean. It's almost has an internal intelligence. And this is what I call a downstream problem. Okay. So if you look at classical descriptions of bile gastritis in the textbook, there's about 2 to 3 paragraphs written in about 2,000 pages. And some of the treatments I see still in classical textbooks is diversion gastrostomy and trying to bring the small bowel loop to bypass that. But there's not a clear answer why the bile is backing up into the stomach. It's supposed to go down. Bile comes out from the liver. It should supposed to go, but there should not be any bile in the stomach. I never thought this was normal. But the other part which I found this, and this is very, very subjective, but if you do an endoscopy, many times with the presence of bile gastritis, the pyloric channel is open. This is what I call the O sign. It's just like, it's like an open, I say, hey, come on over. I'm just opening the door for you to back up with the stomach. And obviously the presence of the bile in the stomach irritates the stomach, and it can cause alveolar hyperplasia, bile-induced gastritis, and the clinical presentation in the patient is generally gastritis-type symptoms, epigastric pain that is unexplained. And I think a lot of these dyspeptic scenarios that we have heard, the non-ulcer dyspepsia that are not necessarily related to Helicobacter pylori, is probably bile-induced gastritis. So we started to investigate our patient population that they came to me, and generally we thought that they were chronically ill and immune suppressed, which is a scenario and a setup for gut dysbiosis. And when they came with epigastric pains and they had seen other physicians, there were no answer. And I said, look, you probably have bile gastritis. Now we can demonstrate that sometimes by doing a Heidelberg pH testing, because you can see fluctuations of the stomach acid. And it's what I call a sawtooth appearance. Or if you do an endoscopy, before you suction anything, if you look, there may be evidence of bile in heavy amounts, in small amounts. Could be bile stain, it could be flakes. But again, is a telltale that there is something going on with this backflash. Okay, and a downstream problem. So we have numerous cases on this. I wish we could publish this, and I may be getting a little too old to do this, because this last article we have submitted for publication, it has almost taken 2 years of intense work and a lot of money to do it. At a private practice setting, it has been quite challenging. But we think this is real, and I think that bile gastritis is related to proximal gut dysbiosis. When the very beginning of the small bowel is contaminated. The first patient we did, and that patient, if she's going to listen to this talk, she would know who she is, because she asked me, am I your first patient? I said, yes, you are. Okay. Because there came someone who came with 3 years of epigastric pain, and there was evidence of mild SIBO. It was not necessarily methane, it was just a mild to moderate hydrogen-producing scenario. Significant amount of bile in this, and when we aspirated the juice and we looked at the juice by PCR, there was whipworm showing up by PCR. So I treated that patient sequentially with multiple anti-parasite protocols, okay, and over about 3 months, she was almost pain-free. She returned after a year. Okay, she said, I'm 95% better. I'm eating everything I want. And she asked me to repeat endoscopy. We did. There was no more whipworm, and the juice was clear in the stomach. So I have documentation on this one case. And if I had some fellows in my office, I'd probably have them write the case up to have a case scenario on that.
You know, I did this really interesting podcast with Dr. Jason Horolak about parasites, and we both agreed that we barely ever see them on the stool, meaning that, okay, blastocystis and dientamoeba, we're sort of taken off the table in terms of parasites at this point. You know, there's only a few instances where we see them to be a problem. So eliminating those two protozoans, we barely see any parasites on a stool test. And I wonder if that patient that you just described with a whipworm, did you find whipworm on a stool, or did you only find it by endoscopy? And would that, you know, how often would we possibly, could we assume that there is potentially a parasite in the upper gut that we can't really diagnose with the technology or the diagnostics that we have available in clinic?
I think it's quite common. I mean, we have done about 100 cases so far of this type of scenario. And
you found 100 cases of whipworm with an endoscopy?
No. We have done 100 cases where we did analysis of the duodenal aspirate, the duodenal juice. I mean, it's a little bit of labor-intensive work, and you have to almost know what to do. But we have obtained duodenal juice, and about a third of those patients, they had evidence of parasite. Occasionally, Giardia in a small amount. It shows as a low signal coming on the PCR. But it's not just the whipworm. Okay, we have had pinworm. We have had other types of parasites showing. I think we had one case of Necator americanus, showing up, a hookworm. But you see, these are the type of things you don't see in a stool sample. It doesn't matter how you do it. It's just you can't. Because I don't think they disintegrate before you get there. And parasitology of the upper part is just not. It's not done. And I know some practitioners, they just treat what they call like a parasite protocol. I mean, they do treat empirically based on assumption that is there. And not all of these patients have abdominal pain or they have diarrhea. Indeed, one of the scenarios that it is poorly described in classical books, you know what it is burping. Is excessive eructation. Yes. Okay. This is, to me, is another symptom of downstream problem. Okay. And we have had numerous cases of this. I always operate based on this premise that this is not a psychological problem. I don't need a psychiatrist on this one. There is probably alteration of gastric distensibility, gastric distension, and gastric accommodation, which has changed, but it is changed as a consequence of physiologic alterations in the small bowel. So the focus should be in the downstream to be able to help the patient. It's a generally difficult problem to correct, and it may require multiple hits of different, and sometimes you just have to do empirical treatments based on what you're thinking. We had one young man who was not from here. He was from Asia. He did not speak English. He came with somebody who spoke English. We kept him in the US for 4 months, but his eructation was so loud, he actually had to make a recording of it for me to see how, vigorously the air was coming out, making a loud sound. So obviously for him to come and seek medical advice, he was not feeling well. I did ask him, he had eaten some raw meat in Asia, so I had to argue whether he might have had some flukes or other things. And we could not demonstrate all of those things. But interestingly, he did have some fungal elements in the stool. But I treated him for that. He also had some SIBO. But I also added parasite protocol to that. And after about 3.5 months, he did write me an email and said, for the last 17 days, I have not had any burping. Can I go home now? And the answer was that, yes, you can go home now.
Yeah, burping and even rumination syndrome. I've had a couple of cases with rumination syndrome where people are sort of regurgitating their food. And so I always thought this was directly related to high methane because, I haven't seen the research that demonstrates this retrograde motility that we talk about with methane, or that I've heard it, several experts talk about this retrograde motility. Do you think this is why I definitely see more burping with people with high methane than, let's say, high hydrogen? Do you see that as well?
I don't categorize it based on methane alone, but obviously methane would be one factor. But if there's high methane, then I'm suspecting presence of fungal elements. But occasionally people have other things, and I cannot ignore the issue of parasites. I mean, these
interesting.
Microbial agents, they could coexist. In the patient that I was just telling you, the earlier one that had the bile gastritis, she did return after a year, and we did the repeat breath test, which was abnormal. She had no symptoms. She said, I'm still 95% better. So I think it was the parasite that was the player. You follow what I'm saying? Because when we did, I told her, look, I still see SIBO. It's not very severe, but what am I going to treat? Treat the test or treat the patient?
Exactly. Yep. That happens.
So I decided, I said, look, just do the right thing, eat it slowly, don't eat late before you go to bed, and don't eat some of the high lectin foods and stuff. And, I think you can keep it under control. But most importantly, don't eat raw food, particularly raw meat, because you're going to try to recontaminate again yourself.
This just reminds me probably, now this dates me, but about 30 years ago when I went through naturopathic medical school. And at the time, we were also taught that parasites often or can hide out in the gallbladder, right? So this is another little pocket where parasites can actually hide out. And at the time, we were taught about doing the gallbladder flush, which is basically, a particular diet, and then you basically drink a cup of olive oil and you have this massive release of bile. And I don't do it that often because people are pretty too ill to do this at the time. But I have had a few people that reported that was like their turning point. They after that felt amazing digestively. So this is something I've always had in the back of my mind as a potential, and perhaps doing that and then doing a stool test just to see if you would capture some sort of parasite or so. That's something. But I just thought it's an interesting thought that parasites can live in the upper gut without any evidence in the lower gut, which really renders all these stool tests somewhat useless, because like I said before, I barely see parasites on a stool test. Very rarely do I see something.
I mean, I totally agree, and that's our experience also. But that's why I said some of these non-ulcer dyspepsia patients, which has been described as a functional bowel disorder, and they have some criteria. I mean, I personally can't go with that criteria. I mean, I think it's usually a structure problem. It just hasn't been adequately defined. It probably needs some of the neurotechnology. I know Dr. Pimentel is, going to be publishing some of his data on the microbiome of the small intestine, and we'll see what we learn from that. But the combination of, high methane or fungi or hydrogen-producing bacteria or parasites, any of these things that contaminates the small bowel, it may give you these type of upper GI symptoms. and the excessive burping or eructation, epigastric pain, and just burning sensation in the upper abdomen. In a chronically ill patient, most likely this is biliary gastritis and is related to the proximal gut. And some of the problem may come from the gallbladder, as you pointed out. And I see the gallbladder as a foci that can become inflamed, and it becomes part of the systemic inflammation. And this was actually published in a journal of hepatology, our classical journals about it. And when you see gallbladder inflammation, you may have to think about this as being part of the systemic inflammation. And the question is that, well, if the gallbladder became contaminated, and is partially inflamed, and may have a sludge or stone, is it possible that every time that it pushes the bile out, it contaminates the small intestine? And I found one reference. I think it was one of the references by Dr. Mullins in his article, that people who have had cholecystectomy, means that the gallbladder was removed, they had apparently less chance of getting SIBO. Okay, so wow, the gallbladder comes out, they have less chance of SIBO, so maybe I removed what was constantly, contaminating it. And is it possible that recurrent SIBO, it could be a manifestation of a gallbladder problem? Now, it could be bacteria, it could be fungi, it could be parasites. And just for your information, we used a laboratory here in the US called Aperiomix, and we had one or two patients where we sent the gallbladder tissue after cholecystectomy in patients with Lyme disease to see if they can see, some elements in there. And in one of them, actually, was very interesting. There was fungus showing up in the gallbladder.
Wow.
Okay.
Yeah.
Well, was that contributing to the clinical picture? Okay. Because this is the type of guy who had recurrent pain and had no stone, and just really bad malfunctioning gallbladder. So you have to do clinical judgments because no test was showing anything positive. But he felt good after the gallbladder was out. Okay.
Talking to you always kind of raises a whole lot more questions in my mind. It's always so stimulating. That's awesome. Right. So being mindful of the time, we have a couple more minutes left to kind of wrap things up. So I wanted to just bring people back into this conversation of methane, the presence, especially of high methane, should raise your suspicion. I think we can agree, right, Sam, about that it should raise your suspicion that there is a fungal presence possible, right? Absolutely.
And just for the audience information, the presentation that I gave last year at the SIBO conference, I was able to work something out with your colleagues and with the coordinators of the conference, and I got the video back. It's a 1-hour presentation, and we put it on our website.
Oh, no great! Charge. Oh, people have access to that.
Yeah, it's no charge, because otherwise they had to pay some fee to be able to watch it. But it is free, and I believe that it's quite unique, those discussions, because I haven't seen it in years of practice. We had to put this data by brainstorming, and we put a lot of effort to put that presentation together. And I do believe it would be worth, taking a look at it.
That's very generous that you're offering it to the thousands of people listening. We will have the link to that, to Dr. Rahbar's website, in the show notes, and you'll just have to send me that link.
I will send you
so that I can put it. Yeah. So where can people find you? Where are you practicing? I know all of the links will be again in the show notes as well. But just, are you were with a group of gastroenterologists?
My practice is basically me, but there's another GI doctor who's a friend and a colleague of mine, and he's in the office. So generally, two of us or one of us is always in the office. Okay. I practice right here in LA, Los Angeles area, and it should be easy to find us.
Okay. Well, we will definitely put that link in there. You're gonna
Thank you.
I'm amazed that you still have space in your schedule. That's crazy. That anyways, we'll put that in the notes. So look, it's been so fascinating, and I will definitely keep my eye out for, well, not just my eye, but with some of these thoughts that you have raised, I will consider this a lot more closely, especially with some of the upper gut symptoms that you talked about. So that kind of puts my thinking hat on a little bit more, again, for those people with really chronic dyspepsia, that even just treating SIBO isn't enough. So thank you for all of your input and for your free thinking, free sort of putting things together. It's been a real pleasure, and I really appreciate the time, Sam. And hopefully
Thank you so much. I appreciate the invitation.
We will meet again, my friend, at one of these conferences once all the craziness lifts, and we can actually have physical conferences again. It will be great to see you.
Absolutely. Thank you again.
Thank you for listening to the SIBO Doctor podcast. We hope you find the information in this episode useful in the treatment of your SIBO patients. Thanks to our sponsors, SIBOtest.com, a breath testing service with easy online ordering, and Quintron, the maker of outstanding breath testing equipment. Thanks again for listening.